All right, I think we're ready to get started for the afternoon session. And we've got our panel now, which is full of our carriers operating in the state. In an effort to try and keep the same sort of discussion going that we started this morning around benefit design and cost sharing, we're going to ask the carriers to respond to a number of questions. The format's essentially going to be the same as it was the first panel. I'll ask a number of questions. Some of these are targeted specifically at particular people on the panel. We've got a diverse group, and some of them are more appropriate to respond to some of the questions than others. But that being said, any of the other folks on the panel can also respond. We will allow questions from the public after about, we've got 70 minutes in total. I'm going to try and budget at least 20 minutes for questions from any of you, but we'll see how things go, and we'll work from there. So on our panel, we have our major carriers operating in the state. I'm just going to announce their names and their titles, but give each of them a chance to say a little bit about what they do for their organization, particularly if their responsibilities impact the decisions their organization make around benefit design and cost sharing specifically. So beginning with, I guess I should go down from top to bottom. We've got Maria Proulx, who's a staff VP of strategy, East Region and National Provider Solutions at Anthem Blue Cross Blue Shield.
Thank you, Tyler, and thank you for having me. Good afternoon, everyone. So as Tyler mentioned, I am the Staff Vice President of Strategy, and I oversee Anthem's East Region, which includes Maine, New Hampshire, Connecticut, Virginia, Georgia, and New York. I'm sure you didn't think Georgia was in the East, but it actually is, at least at our company. And I also oversee strategy for our National Provider Solutions Department, and that's actually across our 14 markets, as we are present in 14 different states. And so my responsibility is really to work with the markets to develop strategies that work within their specific markets, and then also implement strategies that we see from an enterprise perspective we feel are very important that should be present in each of the markets.
Great. Next, we've got Beth Roberts, who is a Senior VP, Regional Markets, Harvard Pilgrim Health Care.
Well, thank you, Tyler, and happy to be here today. So my role is really to oversee our regional market presence and to develop growth-based strategies based on each state. So Harvard Pilgrim comes to the table understanding that every state needs something different to grow and succeed. So the idea is that we have vice presidents that run each market, and those vice presidents all tie into my responsibility. For New Hampshire in particular, I'm also the feet on the street, as we call it in New Hampshire, where leading the team to actually design the benefit and cost sharing and the provider relationships in the community, and all of that reports directly into me as well from a design of strategy perspective. So that's my direct link to New Hampshire.
Thank you. We've got Tim Bulat, who's an actuarial senior director with Cigna.
Yes, hi everyone. I'm Tim Bulat. I lead the market and product pricing team at Cigna. So there's two pieces to that. One is the fundamental market pricing factor development, things like our rates, our trends, our state filings. But then the other side of that's the product development, and this ties into your how do we influence cost share product design. My group also consults on all new product development, whether that be what-if analysis around cost share or valuing narrow network products or alternative reimbursement structures. So sort of traditional pricing as well as new product development, and the team of actuaries. That's my role.
Great, thank you. Next, we've got Michael Gendreau from Community Health Options. I always want to say Maine, but it's now just Community Health Options, correct?
That's good. Thank you. Hello, everyone, and I'm happy to be here. And so my role is I'm the Director of Outreach, Education, and Communications, which is a long title to put on a very small business card. And that's for both Maine and for New Hampshire. And part of my role is in reaching, if you will, consumers both on the individual side and to a certain extent on the group side as well, to help them more fully understand what's available to them, to understand the marketplace and how the enrollment process goes. So there's a lot of education and outreach that takes place within the two states. But in addition to that, it's really member engagement as well as to how we more fully engage our members with their health carrier and with their own health and well-being, so they become, if you will, their own best advocates. In terms of impacting the development of plans, as part of our role, the outreach team facilitates on a regular annual basis focus groups with members. So it's bringing back member feedback to the table as we look at developing our plan designs and cost shares.
Thank you. And at the end of the table, we've got Scott Colby, who is the Vice President of Regional Operations and Executive Director, Minuteman Health.
Thank you, Tyler, and thank you to the department for inviting us in today. So, again, my name is Scott Colby, and I have overall responsibility for Minuteman's operations in New Hampshire, including a say in dotted line relationships, reporting relationships with the contracting function, the provider relations function, the outreach function, customer service, and actually IT as well. Recently, the sales function for the organization began reporting up through me for both Massachusetts and New Hampshire. So Tyler, to your specific question, yes, my position does have an impact and a say and a determination on the benefit designs that Minuteman will be offering in the future.
Thank you. It occurred to me as well, I didn't actually introduce myself. I work with the insurance department. I'm the department's health policy analyst and played a fairly significant role in trying to pull people together. But really, I want to thank the folks that are on this panel, as well as those that participated on the provider panel. They did this really at a request from me, and it's great to see such good participation in this hearing. We're going to start with a question for Maria Proulx. Although several of our companies operate in multiple states, Anthem does have the unique perspective, and Maria specifically, of seeing how New Hampshire is unique or potentially the same as some of the other markets that they operate in. So to the extent there may be consumer preferences that are different, cost sharing that tends to be different, I've asked Maria to describe some of the trends and characteristics that may vary or be the same for New Hampshire. So specifically, cost sharing for Anthem products outside of New Hampshire versus those in New Hampshire. Is the cost sharing higher here? Are the consumer preferences the same, or are there some differences?
Sure, thank you, Tyler. So I'm just going to hit on a few of the differences. So what I tried to do is Tyler had given us these questions in advance. I went through the report, and I'm going to try my best to give some perspective that also ties into what we see in the Gorman report. I think for the most part, after reviewing the Gorman report, I agree with a lot of the conclusions I think that were drawn in the report, namely that we are seeing some higher deductibles. We do see more cost sharing in the small and individual markets as opposed to the large group markets. And then, we agree when we look at the municipal and state accounts, we see lower cost sharing. So, then I tried to look across our 14 markets, and not just across our 14 states, but also we have what we call national accounts, and that's a whole section of our company that just sells to the mega accounts like Google, Bank of America. Those are some of our very large national accounts, to see what the trends were there. Interestingly enough, and I think this was actually a learning process for myself, one of the things that stands out in New Hampshire is the penetration of HMO products. So we are actually the only market across Anthem's 14 markets that has this much penetration. So we have, I believe, 84% of our business sits on an HMO plan. That is very different from both our other markets as well as, of course, our national business. Because as, of course, with a PPO plan, there's that out-of-network coverage. HMO is really predominant in New Hampshire, and when I started to think about why, I think for Anthem, we do offer a regional HMO. So in a lot of our other markets, an HMO is more closed, meaning there's a certain network of hospitals, you must use those. We are very fortunate in New Hampshire to offer an HMO that allows our members access to hospitals and providers in Maine, Massachusetts, Connecticut, Vermont, Rhode Island. So in offering that regional HMO, I think that's probably the biggest reason why we are such an HMO-heavy market. In looking at the report and what we talk about a lot in New Hampshire, we have a very high cost of health care. I think all my research did was validate that. Out of our East Region markets, we're actually second highest in net claims and premium. Interestingly enough, what I did not expect to see, we're behind Connecticut, so Connecticut's higher. I actually think consistent with the Gorman report, Maine was low. That was surprising to me. I actually expected to see Maine being a little bit higher than New Hampshire, but they're actually low. With regard to deductibles, and I know I wasn't here this morning, but I tried to catch some of this on the live stream. I know there's been a lot of discussion about cost sharing. And so we agree that there is some high cost sharing, and we agree it's really right now we see it in the small group market because the individual market is so heavily subsidized by the Affordable Care Act. I would point out two things though when we start talking about the high cost sharing in New Hampshire. The first being that despite the high deductibles that we oftentimes focus on, we have the lowest penetration across the Anthem markets in CDHP plans, so those consumer-driven health plans, the high deductibles. So despite what we perceive as very high deductibles, we don't see our employer groups moving into CDHP plans. Now, that's obviously Anthem specific. I'm sure other carriers could speak to their penetration in CDHP plans. So that's one sort of interesting point. And when you look at our national account markets, it's almost entirely CDHP. The second is that for Anthem in New Hampshire, when we look at the employer markets, we are most heavy in the gold plans. And so if you just think about that for a minute, we talk so much about the high deductibles, but most of our employers are in the gold plans, meaning there's actually a lot of room left for employers to buy down and make those deductibles even higher. And when we looked across our markets, we do see a lot of the markets, a lot of the 14 that are high in gold, but the difference we see is they're also high in bronze. And we actually don't see that in New Hampshire. In fact, I believe we're down under 4% of our small groups actually choose a bronze plan. So I think those are just two perspectives when we start talking about the high deductibles in New Hampshire that I would share with you. I think then I'd probably just touch briefly on network. So we've talked, I heard this morning there was a lot of discussion about narrow networks, limited networks. Frankly, we don't see an uptick in narrow or limited networks across the country in our 14 markets. New Hampshire is actually one of the highest, and that's only when you take individual and small group and put it together. And I think this was somewhat explained this morning when Jen was presenting. That's basically because I think we forced that consumer market into a narrow network product on 1/1/14 when the exchanges launched. But when we take a narrow or a tiered and we put it alongside a broad network across our 14 markets, we don't see employer groups choosing those limited or narrow networks. Now, we still believe in them and we believe there's value in them, and in fact, we will launch a new tiered product in New Hampshire on 1/1/16 in the small group market because we think that it will take hold at some point if the premium difference is enough and the discounts we achieve through it are enough. But that is, when we talk about narrow and tiered, it's really, we're seeing it, I think Gorman, concludes this in their report, it's really in the individual market, and it's because there were no other options. I think the good news is it's worked, and I think for the most part, our individual customers are satisfied. Now, perhaps that's because we have 21 of 26 hospitals, and so it's not as narrow as perhaps some narrow networks might otherwise be. But that certainly was, one point to point out. And then finally, and Tyler, I have a few other things, but I'm sure you probably want to move on from me. On the consumerism front, I think, the specific question I got was large groups and do they really believe in skin in the game? And so I spent some time with our national account sales folks, and from their perspective, our accounts like Google and Bank of America, those big mega accounts, they absolutely believe in it. And they would not offer CDHP plans if they didn't. So there's a real push in our national account space to be in CDHP plans and to force consumers to have skin in the game. On the local market perspective, it's a little bit different. So that would be your 14 markets. We see brokers are very much in favor of this skin in the game. Employers, it's taking them a little longer. They look at the plans and they say lower premium, and that's the first thing they see. Then they talk about, okay, what tools and resources can you give us, can you arm us with that will help our employees make informed decisions? So I think, we see just a difference between what your national account employers are asking for and then what some of our local group large accounts are looking for.
Great, thank you.
Yep.
Anybody else on the panel like to respond to the question about what's unique in New Hampshire versus some of their other markets?
Tyler, the only thing I'd like to add is from Minuteman's experience, and we've only been in Massachusetts for 2 years now and in New Hampshire for 1 year. But when you ask the question, are consumer preferences the same or different in New Hampshire versus other parts, we can speak, I think, in greater detail about the individual market. Our presence in the group market at this point is very small but growing. And what we've seen is a preponderance of bronze plans being sold here in the New Hampshire individual market for us, and some silver, but in Massachusetts, it's been much more silver and gold. So there are some differences, we believe, in the individual market and preferences as far as that willingness to accept high deductibles.
It's interesting. It's in contrast a little bit to what Maria has said about some of the group purchasing at the gold level being so popular.
Well, I'll just clarify. So in the individual market, absolutely agree. I mean, we're predominantly or silver, excuse me, because of cost sharing subsidies and the advanced premium tax credits.
I can add that's Cigna, which is primarily commercially focused here. Similar pattern as Anthem in that relative to the rest of the country, there's actually less employer take-up of the high deductible plans here than elsewhere. So different than, I guess, individual, and also different than the rest of the country.
And I would just suggest that it might have something to do with what our books of business look like as well, right? So you have Anthem and Cigna, which are large carriers who tend to get more of the large national accounts. They're going to buy a different product than carriers that play more in the individual and the small end of small. So I think the sensitivity to CDHP and high deductible plans, it's more closely tied to the smaller you go, the higher the deductible tends to be. So if you're in a micro group of 1 to 9, you tend to buy a higher deductible than perhaps a very large group. So I think depending on the footprint of each one of us up here, you're going to see a slight shift in if it's gold, silver, or bronze, that is more predominant.
Yeah, no, and I agree with that. That for us with Maine and New Hampshire, we're seeing a lot of similarities actually in terms of both on the individual and group side. That the product people are selecting is much more in the silver range.
Great, thank you. So this morning we talked a lot about how the patient is responding to their higher cost sharing, and in cases where they're not seeking out the care that might be medically appropriate. So the question for Beth is, according to a recent analysis of employers' insurance claims by Truven Health Analytics, they observed fewer workers going to the doctor, getting lab tests, even for preventive care when fully covered. So the question is, do you believe that reflects experience in New Hampshire, and how effective can an insurance company be in changing this outcome? Or do you feel that more of the responsibility lies with the healthcare provider?
So what Harvard Pilgrim has seen in our data specifically is more that it's flat. So we haven't seen this dip in prevention and lab necessarily, that it's more been flat. That said, let me address some of what I think might be going on in that data. We have new folks in our insured pool that haven't been insured previously. In that environment, if folks haven't historically been used to forming a relationship with the primary care provider, but more have used the emergency room as an example of a type of service that they go after, they're not used to creating that link with an insurance carrier, primary care provider, getting the preventive care and getting the lab. Do I think it's important for the insurer to take a role in that? Absolutely, yes. And I think all of us up here would say that we spend a lot of time trying to educate our consumers on plan designs, and that you can go for preventive care, you could go for labs, and it's going to be covered in full. The problem is people don't usually pay attention to their plan design until they need to use it. So as much as we stand in front of them and try to articulate what the plan design looks like, they're like, yeah, they leave. Then they need to use it, and then there's a surprise sometimes. And so getting them to understand that they can go for preventive care and preventive labs with no cost sharing is sometimes tough. So I think earlier we heard, should the providers take a role in this? I frankly think that's really tough to ask the providers to do. Our plans are so nuanced, good or bad, but amongst these carriers and even within our own plans, they are so nuanced that I think it's a real risk for the providers to try to educate themselves on those nuances and be the voice to the customer. So I think it requires us to continue to push on that. I also think with plans like Harvard Pilgrim just came out with a partnership with Dartmouth, Hitchcock, Elliott, and Frisbee called Benevera Health, part of that is to try to crack this nut. What we're trying to do is blur those lines between insurance and provider. And with that, if you have a delivery system that is very familiar and intimately familiar with the Harvard Pilgrim plan designs, then they can take on a little bit of that advocate role and indicate, well, you know, for Harvard Pilgrim, you could come in for a preventive visit and it won't be a cost share. Or you could go for these labs and it won't be a cost share. So part of that new development is to try to get the patient where they are. I think that was the words that Henry used, is you have to talk to the patient when they're ready to be listening to you, and how best do you execute on that. And I would suggest to you, it's hard for the provider to do that without intimate knowledge of all the variations in plan designs and, frankly, lab panels. I mean, we think sometimes, or people think they're going in for a preventive lab, and then it flips into the non-preventive lab, and they're like, wait a minute, I thought that this was all covered, and then they get a surprise bill, if you will. So I think that's a lot to ask them to take on, but we certainly have a role, the insurance carrier. I think in new systems where you're blurring that line between insurance and delivery system, taking on that role would be very helpful, and that's certainly the direction Harvard Pilgrim is going in.
Great, thank you.
Yeah,
Other comments from?
Yeah, I agree with that, Beth. Well, like you, we had many people who joined Community Health Options who had never had insurance before. And people don't typically think of their insurance until they actually have to use it. And so one commitment we have to our members is that when people sign on with us, in the first few months, we provide an onboarding or an orientation to their plan. And so it's telling them more about what actually is in their plan, what the preventive care services are, how to use those, but then it's also about helping them understand how health insurance works. So it's that Health Insurance 101, what is a copay and what is a deductible and so on. But then it's helping them understand how to read their EOBs, how to read their accumulators in their member portal, how to set up their member portal, how to select their provider, where's the best place for you to go to get your care. If you broke your arm, does that mean you go to the emergency department or urgent care? And so helping them understand that so that they have a little more confidence in being their own best advocate and being able to have the tools and know how to use them so they can take care of their health and actually manage some of their out-of-pocket costs.
Yeah, and I'd agree with that. I'd take a little bit of a different approach. I completely agree. It's our job as a carrier to arm consumers with the tools they need to understand their benefits. And I agree with Beth. We cannot expect providers to understand how every benefit plan works. But what I would also suggest is we firmly believe that we want our primary care providers in New Hampshire driving this care, meaning we want them to have the relationship with our member to be ensuring that that preventative care is happening. Our Enhanced Personal Health Care program, which we launched 2 years ago in New Hampshire, is completely focused on giving PCP specifically extra compensation so that they can work with our members to make sure that they're getting in for those preventative care visits, so that they can take time outside of that office visit to look at their patient panel, to decide what each of their patients need. And so, when I looked at the question, that's the first thing I thought of is, yeah, it's our job definitely to give them the tools, consumers the tools they need to understand how the benefits themselves work, but we really want to arm our PCPs with what they need in order to provide the services to get those members to those office visits.
Great. Scott?
And Tyler, I would add, along the lines of what Beth was saying and in support of what Maria was saying, is that when we take a look at this population, particularly here in New Hampshire, a significant portion of our individual members have yet to choose primary care providers. So it just speaks to the fact that they are not used to the system. Mm-hmm. And like Mike said, the onboarding process that they have is really important to educate people around this new benefit, this new part of their life where they may never have had access to the system. So what we're doing as well is we're launching partnerships with key providers in the state to actually go a little bit in between and encourage them and pay them to reach out to these members to bring them in and help them understand what actually is covered. We're not going the full way because, to the points made, the health insurance benefit plans are highly complex and vary significantly even within a carrier. But to educate the member, these patients, on the basics of the health plan by the provider and bring them in that way, we think there's value to that, and that's the direction we're going.
I think based on what we heard this morning, and it's sort of a follow-up question for any member of the panel, is that, I think that by the time the patient really needs to know this information, they're often walking in the provider's door. So to the extent that there's been an opportunity, it's sort of come and gone, or at least for some folks. So do you have any specific training for providers, or what is your connection? I mean, are the resources being emphasized in kind of online connectivity to people's benefit designs? Is it more sort of modules that are training? How are you interacting directly with providers? I know, Beth, you mentioned your direct relationship, but what about the folks that you don't have that kind of relationship with out there?
I mean, I'll just say our goal with Benevera, you're right, we have to roll it out first to our partners, and the idea is to tool them up with the information so that they understand the coverage designs of Harvard Pilgrim, and that in and of itself is really hard to do. And then the way the model is going to work is there's going to be embedded care managers throughout the entire state. So it's not going to be isolated to just our provider partners that are part of Benevera. So the idea is that it will get disseminated, if you will, throughout the state. It's a pretty big task to do, and it's something that will be rolled out throughout next year, but it is the goal to cover the whole state, not just our partner organizations.
Thanks. Other comments?
Yeah, I mean, I would agree. I think that as I mentioned, the Enhanced Personal Health Care program through Anthem, we do both. We give connectivity through online resources to our providers, and we actually have over 80% of the PCPs in New Hampshire in the program, so it is statewide. And then to Beth's point, we also embed the care coordinators right in the practice and give our PCPs access to those care coordinators, whether they're there in the practice or whether they can call them up and ask them questions. But, you know, I think asking the PCP to take our benefit plan and study it and understand how it all works it is an impossible task. And we would rather have our PCPs working with our members on their care as opposed to necessarily understanding how the benefits work. That's not to suggest, I mean, I think the average physician understands deductibles, co-pays, co-insurance. It's just how that then reflects upon a specific individual's benefit plan.
Tyler, if I could just add, given the size that we are in the state, this is why for Minuteman in particular, it's important to launch these initiatives as a pilot. Certainly, we provide all of our providers with tools, portals to access information, to understand our benefits, a traditional provider relations function as well. Those support services are there, but the reality is, as you come into a new market, you have that provider orientation, you're top of mind, and suddenly the provider rep leaves and there are very few members. So the providers working with Minuteman, for example, may not be as acutely familiar with the tools that are available. So for us, as we grow, there'll be some inertia, which is why piloting with certain provider groups has been our strategy.
Well, you know, and that actually makes me think of something else. You know, one of the challenges we've seen with the launch of the exchanges since 2014 is the churn. Meaning individuals are coming into the market and then they're quickly exiting the market. So they sign on for a plan at the beginning of the year, and then by 6 months in, they've decided, oh, I haven't really used this, I need to pay this bill, I'm not going to pay this bill, I'm going to jump out. And that cannot be easy. I mean, that's hard for us, but I actually worry more about our provider community. Because, you know, with the ACA comes this thing called the 90-day grace period. And so, like, there's an example, and Scott made me think of this, of a tool that that carriers should give the providers. And that's access to information about these individual members. Are they still active with Anthem? Are they still an Anthem member? So to expect them to understand Anthem benefit plans is one thing, but then understanding if they're even still our member on a day-to-day basis with this new individual population is very difficult. So I think we do have to do our best to help our providers have access to that information.
Thank you. Question for Tim. Could you please explain deductible leveraging and your opinion about the impact on premiums and future product development?
I'm glad you're here to describe it.
Actuarial question, huh? So there are two parts to the question. There's the actuarial lesson in it, and then the opinion on what that means for plan design. So deductible leveraging, what this causes is healthcare premiums to rise at a faster rate than total healthcare trend. The reason this happens is if a plan design has a fixed deductible from 1 year to the next, say that deductible is $1,000, then the portion of the spend that the patient is responsible for is capped at $1,000 year 1, year 2. It doesn't increase. The total medical cost increased by whatever it is, 4 or 5% year over year. If the member's portion didn't increase, then what the plan's paying increased by more than 4 or 5%, so that the average, the total is 4 to 5%. So what you typically see is if you didn't increase the deductible on a plan design from 1 year to the next, the trend or the increase in the health insurance premium is about a point higher than the overall trend for medical cost. The impact that has on plan designs, this ties very closely to all the benefit buy-down conversation we were having earlier. That is how first, mathematically, that is how you would keep the trend equal between the member and the plan. If healthcare trend was 5%, then if you wanted a 5% trend to be the health plan rate as well as the member rate, you'd have to raise your deductible by about 5%. First of all, you don't want to raise the deductible every year. And second of all, if you do like a percent, like 5%, you end up with odd deductibles like $1,050. So what usually happens, the way employers at least, and I primarily support employer purchase plans, is the employers will deal with the leveraging for a few years, and then there's a big benefit buy down all at once when it just becomes more, when they're looking to really save a big chunk of that expense. But benefit buy downs is the reaction to leveraging. It's the way to even out the trend between the plan and the member. A couple other points on leveraging. You only see it when there's a plan design feature which is dollar based. So it happens with copays copays as well as deductibles. Coinsurance, naturally, because it's a percent of the spend, the member portion increases as does the plan portion. So the more plan construct is around coinsurance, the less leveraging you see, the less you have to put through what looks like a benefit buy down through a deductible increase. But then out-of-pocket maximums, which are now in many cases, the employer selects out-of-pocket maximum, but the maximum out-of-pocket maximum is a legislative requirement. That out-of-pocket maximum, if it does not increase with trend, will also drive leveraging. Though at this point it is increasing with trend. But just some things to keep in mind as you're looking at a plan design. If you see stuff that's defined as a dollar amount, it's something which, if it's not trending, it's going to cause leveraging. If you see something defined as a percentage, it will not. So I hope that helps. Thanks for the actuarial question. I wish I had a chalkboard. I could have done it better with
Thank you. Would anybody else on the panel like to comment on deductible leveraging?
Sure, let me give you my speech.
I don't do math with letters.
Okay, next question is for Michael. And to the extent we go through these questions, we can always circle back, and certainly any of you folks can ask follow-up questions when we get to that point. And this question may sound a little bit similar to the question asked of Beth, but there's a little bit of a difference, and I'd like to get Michael's perspective. According to a Commonwealth Fund survey, 40% of people with private health insurance whose deductible equaled 5% or more of their income said they decided not to go to the doctor when they were sick, or had chosen not to get a test or to go to a specialist. Do you believe those findings reflect the experience of community health options members? And if so, what opportunities exist for you to influence the healthcare provider and in turn their interaction with the patient?
So the short answer is no. But what we have done in terms of developing a plan design that really tries to encourage members to get the care they need in the right place at the right time. We designed our plans in what's called a value-based insurance design model that really is about incentivizing members to access those services that have a high return for them in terms of their effectiveness, in terms of providing them with the best of care. In addition to that, we've built into our program a chronic illness support program where we've targeted 5 chronic illnesses: diabetes, hypertension, COPD, emphysema, coronary artery disease. I think I'm missing one. So for members who have one of these chronic illnesses, for their the routine management of their care, we've either eliminated or greatly reduced those financial barriers that they have to receiving that care. So for example, a type 2 diabetic, on average for the year, assuming that this is a person who is actively managing his or her diabetes, what we find is the average cost of that care will be right around $5,400 a year. Once you factor in what the insurance company pays, it leaves the member with an out-of-pocket of about $310. So much of their care, their routine management, is, as I said, zero to very low cost. So in addition to the chronic illness support program, we've worked very hard at trying to integrate, this was to the panel earlier this morning, integrating medical and behavioral health. So for example, if a member needs to see a psychologist or a counselor, those first 3 visits are at 0 cost to the member, and then it's subject to whatever their copay or deductible might be. So we work very closely, and this is not just on behavioral health, it's also on the substance abuse side as well. So that is one component, again, to try to really ensure that people are getting the right care at the right time and eliminating those barriers that prevent access. Most recently, we've entered into a partnership with Hannaford Pharmacies in Maine and in New Hampshire, where if a member has their scripts filled at a Hannaford pharmacy and it's a tier 1 generic, it's at 0 copay for the member. And that has actually been, for one thing, a huge satisfier to members. But we are seeing members who may have been on a med that was a preferred medication having that conversation with their pharmacist or maybe with their provider. And for some, it might be the first time they've ever had a conversation like this, but they've got a little skin in the game. They might be able to save some money if they are, if it's medically appropriate for them to be on a generic. And so they're starting to have those conversations. And so we're now starting to understand the data a little bit more. So we're seeing those components of our plan and the partnerships that we have in the community as really helping eliminate those barriers so that members are getting the care they need. And in our care managers, we have if you will, a very high-touch organization where our care managers work very closely with members with complex care needs. Again, to ensure that they're receiving the right care, that they're accessing the right services, at the appropriate time and the best service. And so we partner a lot with local care managers as well to ensure that they're getting their care close to home.
Thank you. Any other comments from any other panelists on this question? A question for Scott Colby. It wasn't long ago that a deductible of $3,000 some people would consider an insurance product that wasn't really insurance. I mean, after all, you pay $3,000 before you get anything. So the question for you is, do you feel as though we're reaching any sort of ceiling on the amount of cost sharing or deductibles, and that consumers are simply not going to tolerate that kind of cost sharing beyond a certain point? And of course, there are certain federal restrictions, but nevertheless, do you expect that we'll continue to see that kind of growth as we have over the last few years, or will there be other reductions in benefit designs in order to keep insurance affordable?
So I'm not sure that we've reached the ceiling at this point, but I don't think we'll see the trajectory that we have. Tim did all of that good explanation of the diminishing return, if you will, of the deductible and how it could be leveraged. So I think you are going to see that. I think that the market is going to continue to demand that. To the extent that a higher deductible can, to a certain degree, deliver some lower premium, there's always going to be that there. But to the point you made, Tyler, the Affordable Care Act has some benchmarks or some guardrails around that, right? Squeezing into the actuarial values of the gold, silver, bronze plans, we can only go so far with benefit design. But there's another component of this too. So if you remove the individual from that, and you look at some of the cost drivers and some of the other ways that you can change behavior, Minuteman is banking, and a little bit differently, I think, Maria, than what you said initially, although Anthem might be going in this direction, on a narrower network approach, and working with high efficiency, high quality providers, not to suggest that if you're not in our network, it's because you're not high efficiency or high quality, but the point being that the health plan has a little bit of a different angle in being able to partner more closely with those healthcare providers. And those are the folks who are delivering the care and that can actually manage the population. So I think that's another arrow in the quiver for us. Also, there's another element of whether or not we've reached the ceiling. And that is when you look outside of the individual market into the group market. Employee benefits are a recruitment and retention tool as well. Maybe not as much as they once were, but they still are fairly important to attract qualified, high-end, high-productive employees to your organization. And that is very much part of the benefit package. So how far can an employer go in raising that cost share? And then one other thing I'd like to just suggest, and that is $3,000 used to seem like a lot, and now it doesn't seem like quite as much. But when were the consumer-driven health plans first introduced, right? Weren't those part of the Medicare Part D prescription drug program back in the early 2000s? And that's when we started seeing the HSAs. And I think that's when we started all getting a little more comfortable with higher deductibles and how to manage those. Not as many people take advantage of the HSA model and the tax advantages in this market, but they still do exist. So those are still very high.
Other comments?
I would just add that the more we can do our job to keep trend down, the better we will do with keeping deductibles down. So if you go to an employer and they're only getting an increase of 3%, they may very well keep their deductible. Forget the deductible leveraging for a minute. But I think that that's our job, right? We need to figure out how to keep medical costs at a reasonable level so that we can keep trends at a reasonable level, which will stop the buy down at the rate that we've had. So I'm hopeful. I mean, if you look at the trends over the last couple of years of being in low single digits, that's a promising sign. I think as you start creeping back up to 7, 8, 9, double digit, which we used to be not too long ago, you see much more significant buy down. So hopefully we're finally getting to that balance point. But I mean, we certainly are still selling $4,000 deductible plans easily. It's just not our most popular product.
Yeah, I'd agree. You don't need to buy down if you can better control the cost of care. You don't need to leverage those deductibles as much if you can really focus. And I do feel like it's our responsibility as carriers to make sure that we're doing that. And a lot of our focus at Anthem is on managing the total cost of care. And that's through many different avenues, including consumer tools and transparency tools. Interestingly enough, though, if you look at transparency and you start talking about the tools and the data that's available, I mean, there's no shortage of data out there and transparency tools online. You can find them everywhere. I think what we take away from it, at least at this point as Anthem, is it was not until we started attaching incentives to the use of those tools. So we had a website, a transparency website, probably as far back as NewHampshireHealthCost.org. I don't think anybody ever used it, any of our members. They didn't. But when we started attaching incentives, and those can come in one of two forms, as we do today. We, in some cases, pay our members. We actually cut them a check if they go online and check one of our transparency websites, or it's through benefit design. So I think, to the extent we want to keep those deductibles down, managing the total cost of care is about us taking a responsibility, the carriers taking a responsibility to help manage that cost of care through consumer health, through consumer tools and improving those tools. I mean, we now have all the tools. The next push is mobilize them. We have to make it so that I can pick up my phone because I just got that lab test from the doctor. I'm not going home to get onto my computer. I need to be able to pull that up on my phone and find out where I should go. So making it mobile, it's certainly something we're seeing across our national accounts. We're working on that locally in New Hampshire as well. But I think that is the way, right, to keep those deductibles down.
Tyler,
We're seeing,
Tim?
sorry. At Cigna, just the past couple of years, as trend has been as low as it's really ever been, at least for the past 20 years, the amount of deductible, or the amount of benefit buy-downs the past couple of years is less than it has been back 5-10 years ago when trends were 7, 8, or 9%. So we are seeing employers are able to stomach deductible leveraging when the overall trend is 4%, easier than when it's 8%. The other thing I think that contributes to that, though, is what Scott was saying around the focus on using alternative products or networks to lower costs rather than just cost sharing. As Cigna has introduced, not in New Hampshire, we've done this elsewhere, products centered around provider relationships. So whether it's narrow network or tiering or something which drives incentives to the providers that we have the closest partnership with, that lowers cost without it showing up as higher cost share to the end consumer.
Scott?
I want to touch on something that that Henry Littman actually mentioned in the last panel. That's when you look at the 5% of the population. So I think cost share and maximum out of pocket and deductible, they might have somewhat of an impact on trend, but ultimately our ability to work closely with the providers to help reduce the trend, as you folks said, is critical, because when that 5% needs to access care, I'm not sure, and I'm probably going to get yelled at because our general counsel is listening to this, but I'm not sure they care who their insurance company is. If somebody gets that diagnosis, they want the care. right? So benefit design, all of that, at least immediately, goes out the window. So we want to try to steer them to the high-quality provider that is going to work with them to get them to where they need to be in that really serious episode, that really serious illness that they're battling. So this cost share equation only applies, it only goes so far, right? Because at a certain point, if it's my kid, if it's my wife, right, what are we going to do? That's a hard barrier to get over.
Go ahead. So I'm going to ask one more question. This was directed to Tom Sherman this morning, but I think everybody on the panel had something to say about it. And it goes back to the insurer's responsibility. Does your organization believe it has a responsibility to ensure access to care? And I'm asking the question slightly differently, so please listen. Or do you believe the consumer knows best, and it's your role to simply develop a product that they want to buy? And take responses from anybody on the panel.
I'll just say I think it's everybody's job. I mean, I know that sounds overly simplified, but I don't think our job is just to spin products out there and not care about access to care. I think we absolutely care about access, and we care about affordable access. And I think that's why you see so many iterations of partnerships developing, because if you develop close partnership to the delivery system and you start thinking of the premium dollar collectively as a unit, and you start thinking about how people need to find the right coverage within that premium dollar, and you start lowering some of the barriers to access, and you make sure that people can be seen within 24 hours, 48 hours. I mean, the insurance companies are starting to talk about that kind of thing with the provider community. So I personally, and I guarantee my fellow panelists feel the same way, that I don't think our job is to just spin out products, but to really look at it more holistically than that and find the right partnership models to make it affordable and accessible for everybody.
I agree. I mean, when we were building our pathway network, as everyone knows, 1114, when the exchanges opened, Anthem was the only carrier on the exchange. And we set out, a year and a half in advance of that to build a network. It was partnership with providers. I mean, I give so much of the credit to the providers in New Hampshire that partnered with us to launch those products. Because we literally went to each one and sat there and had long discussions about this new membership that we were trying to bring into the market, and that we couldn't just take, the prices and the products of old and put them on the exchange because they were unaffordable. And we believed, and I think as we've now seen, that the individual consumer that was going to purchase on the exchange was going to be in that 100 to 400% of the federal poverty level, and was going to need lower prices, even with subsidies, to be able to afford the care. And we had long discussions with our providers, and I give our providers a lot of credit, because they took a leap of faith with us to say, we can come together, we can build a network, we can bring down costs. We've seen it in the data, but for that narrow network, prices would have been 30% higher, and we don't believe those products would have sold. So I think it's absolutely an obligation on all of us, carriers, providers, but also consumers, because remember, we can give consumers so many tools, so many resources. If we can't convince them to use it, then it's not going to change behavior. We see that in the municipal and state account, where the report concludes their cost shares are lower, and they don't really have a lot of skin in the game. And I think Tyler and I did an event with all the municipalities across the state a few weeks ago. And what was interesting was we talked about how they have very little cost share. They've got to consider more because the Cadillac tax is looming. I think we all know that. We talked about how we're giving them the tools and resources they need to be educated consumers, but then they asked questions. Well, we don't really feel comfortable asking our doctors questions. We don't feel comfortable if they send us here. Are we supposed to question our provider? And so it comes to a point where you say, we can give you the tools, we can give you the resources. We've got to help them feel comfortable using them.
Yeah, to something Beth said a few minutes ago, I agree that it's not just one or the other, it's all of us. Because it really is on the strength of partnerships and relationships that we're going to be able to move the needle on all of this. And so it does involve working with the provider community. It is about providing your membership with tools that they can access and that they can become more informed consumers and better advocates for themselves. So it is that combination of working in partnership, which is something that for us as an organization that has been a driving force for us, is to cultivate those relationships with the provider community. and with our members so that they can, in fact, be healthier, but have a, if you will, a combined impact on reducing the cost of care. Both in Maine and New Hampshire, our provider network is actually very broad. It's statewide in both Maine and New Hampshire, and that was something that we did early on, was to make sure that our members were able to access care close to home, because we really do feel that as we work with our members, especially those members who have those complex care needs, that people in their community, that the services available to them either locally or in centers of excellence throughout that particular the state, that we want to make sure that they have access to that care, and that we're working closely with them to ensure that they're getting the right care.
Scott?
So, as an insurer, we have a role to collect premium dollars and to pay providers, but we have a greater responsibility than that. And we have a greater responsibility, along the lines of what you all have said, to work closely with the providers to ensure that those dollars are being spent to improve the health of the overall population. We also have a greater responsibility to engage effectively the consumer. And if there's a major change that's occurred, whether you're for the Affordable Care Act or whether you're against Obamacare, it's the fact that the ACA has engaged all of us, because we all have to file our taxes. So at a very basic level, we are all very mindful now that there is an individual mandate and that we have a responsibility, and you have to start somewhere. But I think that's very powerful. And again, not trying to be partisan here, but it's very powerful because the consumer has been forced to engage, whereas maybe several of them, the invincibles, were sitting on the sidelines for so many years, and now they're being pulled into the system. So yeah, we have a fundamental mission, but we also have a tremendous responsibility to work both with the consumer, the patient, the member, and with the provider.
Thank you. I've got a lot of other questions, but I want to make sure I give time for anybody else to ask them. So I think at this point I'll open it up to questions from the audience. Michelle?
I have a general question for all the panelists, with the exception of Mike, because he sort of brought it up. He mentioned the things that community health options are doing for individuals with substance use disorder, recognizing that they are particularly sensitive to cost sharing and that we do have an epidemic. Some of the initiatives that you're doing at community health options. I was just wondering, for the rest of the panelists, are there any things within your carrier plans that you're doing to assist this population, and what do you think that you could do moving forward to help stem the tide of the epidemic that we're currently facing?
So just to repeat the questions that are being recorded, the question is for the other carriers in terms of their efforts specific to patients with substance abuse problems. Who wants to start? Beth?
Oh, I get to start again. Okay. So I have to tell you, I'm a little ill-equipped to answer that question directly, but let me tell you what I do know. So I do know that we've offered additional coverage for certain things that we have not historically covered for, so that I do know. I also know that we are working, and we've done this in another state, but we are working with the recovery environment, if you will, to try to figure out payment models that make more sense, that are less incremental, but maybe all-inclusive, so that we're not trying to navigate people through the system, but we give that responsibility back to the experts to navigate that. We're at the very beginning of those discussions, so I don't have anything to share today, but we absolutely recognize the crisis. We're involved in discussions about it, but I can't tell you one thing, that we're doing right now that's going to make a big difference in that space, outside of working on it collectively with our entity that we partner with.
Yeah. Oh, go ahead.
Scott?
Thank you. Mine will be quick. Clearly, substance use disorders is part of the essential health benefits, and so we have a network of providers and a process to assist our members in that. There's more to do. There's more to do on our end. There's more to do in the state. And clearly, specialty care case management would be engaged at the right level, so those resources are definitely available for those members who are suffering from a substance use disorder. I'm also aware of some legislation that is currently, that's going to be introduced in the special session, that we're currently evaluating right now. I can't speak for Minuteman and the position we're going to take on that, but I've looked at the overall piece, and there are certainly things in there that seem perfectly reasonable. This is a community-wide effort, and this is not an effort that can be addressed by any one stakeholder. This is a larger problem than anybody. So we all have to work together, I think, to tackle this. It affects all of us, all of our families.
Yeah, I mean, I would echo what Scott and Beth said. In fact, we had a meeting yesterday with the governor to talk about this exact issue and figure out, to Beth's point, we don't have anything concrete yet, but absolutely we're engaged in the discussion. It is an important discussion. I think one area of focus we are looking at, though, is behavioral health services in general. I think we recognize there's a need there in this state for more behavioral health services. I think Henry Littman, who's here, has done a great job. His organization has really taken a lead on that. I think what we're doing, we are rolling out Live Health Online, which is a telemedicine service on 1/1 to all of our Anthem members. That provides online care visits, and it's going to provide both PCP care visits, but it's also going to have a behavioral health component. And don't hold me to the 1/1 date on the behavioral health. We're still building what we call that behavioral health ecosystem to have enough behavioral health providers available at all hours of the night to take calls from members who are in need. But we really have had a heavy focus on the behavioral health need in the state for quite some time.
Just because you asked it to all of us, I'll say it. Cigna's got a behavioral network product. It's a big area of focus for us. I'm the wrong person to give more specifics. I'm just not that close to it to give the details to your question.
Thank you. Other questions? Herb?
With the changes in the patient responsibility, the higher deductibles, and all the efforts that you're making with respect to driving members to low-cost option providers and such, what role, if any, or do you see your role changing with respect to actual payment for these services to providers as the insurance company?
So the question is, with the higher cost sharing and the incentives to go to low-cost providers,
How's the role changing with respect to ensuring that the membership, that the members of the health plans actually pay these cost shares?
how is the role changing in terms of ensuring that the members can pay their responsibility? Correct?
Well, I might not understand the question. With the lower cost option plans we have, so our site of service, the goal of those plans is to make the cost sharing lower so that they won't be prevented from having those services. I'm not sure I understand though if that's exactly where you were going with that. Maybe somebody else.
Well, specifically is getting at what role does the insurance company play in ensuring that cost share, high, low, or whatever, is actually paid?
Well, you're talking about perhaps your bad debt increasing because of higher deductibles? Is that where you're going in higher cost share?
Yeah, I mean, I can tell you that's the concern I raised earlier about the grace period, where I am very concerned that there's issues with the way the law is structured. And I think from Anthem's perspective, one of our advocacy items from a regulatory and legislative perspective at the national level are these grace periods, where consumers are given 90 days. And as long as they pay their first month premium, they get into the system, and then they don't have to pay another month premium, but they get to stay on the plan for 90 days. We are very concerned about that. We've been advocating about that for change, because we do think we cover the claims for the first, obviously, 30 days, but then there's the additional 60 days that the providers are potentially at risk for providing services and not getting that cost share. So, that is a huge focus for us, and we think we have to stay close. That's one of the reasons I talked about tools, giving tools to providers so they can actually go into our system to be able to see where a member's at. Have they paid their premium? Are they in a grace period? I don't think there's a perfect solution yet, but I think it is a focus, and I think we have to stay close on that and work with you to ensure that you're getting those cost shares paid.
One of the things, so can we actually go back and can we, boot the person off the island if they haven't paid their deductible to a certain hospital, right? Would we want to do that? Can we do that? I'm going to actually defer to the department on whether, what type of action an issuer might be able to take with respect to a person not paying their deductible, but I don't suspect there is anything an issuer can, nor necessarily would they want to. I can tell you that as we continue to evolve and we look at unique benefit designs and look at what's happening across the country, there are different types of products that can be offered that aren't heavily as reliable on deductibles as, say, this market has become accustomed to. For example, one thing that comes to mind is reference pricing, right? Where you work with key providers and set a flat fee for a certain procedure, and you essentially give the member that amount to spend. And if they want to go to the provider who's accepting it, great. And if they don't, they can shop elsewhere. So there are some other benefit designs that can be employed that aren't necessarily as heavily reliant on the deductible. But again, I'd kick it over to the department to see if there's anything the issuers can do. I don't think there is.
In general, the statutes always make allowances for cost sharing.
I would just like to clarify just on the LP piece, and I think some people in this room, so low-cost provider piece, and I know, Jen, you mentioned it this morning. We have both hospitals and freestanding entities on our low-cost provider list, so I don't want folks in the room to believe that it's all just freestanding labs and freestanding ambulatory surgery centers that are on the list. So that point of clarification is important first. And then the other thing I would say, Herb, is I know the market is shifting, but I think with more and more people becoming insured, at least hopefully that's lowered your bad debt in the way of more people getting insurance coverage means that you get paid for more services for more people. So that's the good part of what's going on. I do agree with you with the increased cost sharing. Harvard Pilgrim does not right now take an active role in helping you figure that out. I'm not quite sure I know yet what it is we could do. I mean, I think we would be willing to think about it with you, but I'm not sure what role we could play without some guidance on some stricter measures around that. But it's not a great answer, but it's the best I can do.
Kathy?
I just have a question. Have the insurers thought about reaching out to community-based groups who already work with the folks that you are talking about being new to the system, who talk to them about financial education, financial management, going to the doctors on time? And if you were able to turn dollars to those nonprofits, I believe that it would bring about a much richer opportunity for everybody to be involved, the community, the insurance products, the medical community, and the consumer themselves, to really begin to understand that medical care and health care is not a standalone, siloed product, but it's part of the life process, and they have to be part of that as well.
Yeah, so I can give you a good example of what we did in Maine in terms of a partnership is with the federally qualified health centers in Maine, where they actually contacted us and we worked with them to develop a series of health insurance literacy workshops throughout the state. And that was not targeting community health options members, it really was targeting whoever the patient was that they were serving, so we conducted, I think, 17 of those throughout the state of Maine as an effort to help people understand.
Were you able to provide some incentive in terms of $1 to the nonprofit to be able to do that?
We provided them the if you will, the manpower. So we were there.
Anybody else on the panel respond?
I mean, similarly, when before the rollout of the exchanges with all of the nonprofits that signed up to be community assisters and the navigator organizations, we worked hand in hand with them right up until the launch, doing classes with them, going around the state, doing different forums to try to help educate consumers, work with them to make them understand how benefit plans work. We're never able to pay them an incentive, but to that point, we obviously were there with manpower.
Those federal dollars have gone away.
Yep.
So that opportunity for people to be able to be in their community and get those answers no longer exists. So kind of to my question this morning, where then is that obligation for the money that it takes for the people to be able to provide not very specific details about individual plans, but about how to use the healthcare system, how to access the information that they may need, and more financial management around how do you save for a deductible, how do you save for your co-insurance, because I think that that's a large piece that's missing, and again, it's that very siloed care where we have
Going back to the responsibility between the carrier and the provider to instruct the patient about their benefits. Sure. Other questions?
Jeez.
Oh, I'm sorry, Jeannie.
I'm over in the corner, Tyler. So I probably should be put in the corner. So the theme of the day is really about benefit design, and it causes me to question: are we at a point now where we have gotten so complex in benefit design that we are not getting the yield from that we think we ought to? And I think about the car, buying a car, and how everybody's gone to no haggle pricing. I mean, are we at the point where we need to go to, some variant of that? I don't think we're getting out of plan design. We're rearranging the deck chairs on a very big, expensive ship, and I don't think it's getting us maybe what we want. Is that what you're trying to get at today, Tyler? Because there seems to be sort of a theme here.
Well, it's that shared responsibility. Who's taking the lead in particular circumstances, and what do we expect from the patients, the providers, and the carriers? So,
Yeah.
Go ahead, Maria.
Maybe that, today the theme has really been about benefit design, but maybe we could have done another full day on all of the provider collaboration work that's going on across carriers. We're all doing it. You've heard little snippets of it from each one of us. But, at Anthem, we have 3 strategic pillars. One of those is provider collaboration, because we believe you can't just achieve lowering the cost of care through benefit design. You have to collaborate with providers. You have to work. I heard Henry say you have to meet people where they're at. I always say you got to meet people and providers where they're at. It's our responsibility as carriers to meet our providers where they're at currently in the system and help them move down the continuum into relationships with carriers that will help lower the overall cost of care. So I think today, you're right, the focus has been about cost share and higher deductibles, but I think you could have done equally as much on, say, just provider collaboration and medical management cost of care.
And I'm very heartened over the efforts that are underway on the part of our provider community here in New Hampshire to improve quality, and inherently in that we're going to improve lives, and ultimately we're going to reduce cost. And there have been tremendous efforts made, and we're very fortunate. Our health system in New Hampshire grades very high on quality, and that's a testament to the provider community, and we're fortunate to have that. Today, of course, we're focusing on benefit design.
I agree with what you're saying, and I think a lot of the benefit design complexities comes from insurers trying to get customers to do the right thing, but it was through benefit design it got really complicated. The provider collaboration work that insurers and providers are doing together now in getting the patient engaged with the PCP who can drive those right behaviors can lead to us making more simple plan designs, because we don't have to force everything through plan design. We do it through relationships.
And certainly, the citizen, I'm with the Citizens Health Initiative. We kind of live in that space between you and the provider. So I do kind of get all of that, but I'm also concerned about the escalation and
I will just say, I think the plan designs are tremendously confusing, so I'll just put it on the table. I think we've gone too far. I don't think, unfortunately in this, I'm not making a political comment, but I do not think the ACA has helped. So we have to meet actuarial equivalents on these silver, bronze, gold plans, and sometimes you're trying to make it fit, and you're at a very incremental benefit design that you're adding or subtracting cost share from to get to the right actuarial value. I actually think it's driven our products to be more complex rather than less. Not that the ACA is bad or the ACA is wrong, but because and I don't think we want fixed plan designs because it takes choice away. But you're playing on the edges, and you're often playing on those edges to get it to fit that AV calculator. So I personally think it's gotten too complex. Now how to dismantle that and not make it more affordable is a very tough exercise. That's Beth Roberts' opinion. I don't even know if my partners in crime in the audience would agree with me, but that's my opinion.
Well, we've got time, I think, for one more question. Just wanted to.
Sure. So, as a consumer, right, that's tried to make, rational decisions that kind of save the cost of care for me, right, and for, the underwriter, I'm an Anthem insuree and I have a pretty high deductible, and, I had an incident with someone where I met with my physician and I said, he said, here's what you got to do. And I said, what are the CPT codes for this? And he said, nobody's ever asked me that before. So he said, go talk to my front desk people. And so I did, and we tracked down the CPT codes. And then I went around and I called providers and I said, here's what I need done, here's the code, how much is it going to cost me? And they said, well, we can't necessarily tell you that information because, that's a contract that we have with the insurer. They said, go call your insurer. And this happened at, the 5 or 10 different providers that I called. And so then I called Anthem, my insurance company, and I said, hi, my name is, XYZ, and here's my number, here's my deductible, here's my co-insurance. I'm looking to get this thing done. I even have a CPT code for you. How much is this going to cost me at Portsmouth Hospital? How much is this going to cost me here? And out of the 10 or 15 times that I called, I think I got one response from somebody on some actual pricing, and the rest of it was, oh, I'm sorry, we're not allowed to tell you that. Well, why are you not allowed to tell me that? I'm actually engaged here in a process of trying to save my own costs, because that's the real incentive, right? I have a $3,000 deductible, so this is going to be coming out of my pocket. I thought that my insurance company was supposed to be on my side helping me try to say, hey, if you go here, it's going to be $200 as opposed to being $1,700 over here.
Is there a question you're
actually
getting
to?
to?
So I guess the question is this, right? How can, you guys as insurers, and I'm sure this doesn't only apply to Anthem, help your insurees deal with this incredibly complicated environment, not only through benefits, but also with providing them, information on actual costs?
Yeah, I think it depends. I think if you call and you say you're going to have a specific procedure, you're going to have an individual on the other line who's going to better be able to assist you in where to go and how to go. That's available now. If you have site of service or Compass, you can call up and say, I'm going to have a colonoscopy, I'm going to have an MRI, what is the cost, where's the lower cost option, where should I go? That information is available today. I think when you start talking about CPT code level detail, how many, ICD-10 just took effect, does anybody know how many CPT codes there were, and then what ICD-10 did to expand it?
It was 10 to 15,000 up to like 65,000.
Right.
That's ICD-9.
And
They're different codes.
right, but my point being, when you get into ICD-10 and you get into coding, whether you're talking CPT or not, your customer service representatives, we can do our best to give them the information that they need to answer questions. Down at that CPT code level, what's going to end up happening is you're going to have misinformation going out the door because there's just not that understanding. It is confusing. I agree with you. You should be able to get basic information. But there are so many codes out there that it's impossible to be given code level detail. It's not impossible. I guess anything is possible. You're right. But I just think it's very difficult.
So, and what I would suggest, I think what's hard is we get worried about giving you the wrong information. So it's a bundled experience, right? And I know what field, I don't know if you're linked to these fine gentlemen next to you, but what we get worried about is giving you the concrete number of hospital X and realizing that there's all these other ancillary services that are going to be provided, and then what you receive or what you see on your explanation of benefits is wholly different than what we told you. That's what we get worried about. That's why I tend to steer people, no joke, to the Health Cost website, because Tyler and his team have made it a bundled experience where it's all services related to a typical episode of care at that provider. I would be nervous if you called me and said, this is my CPT code, tell me how much you're going to pay Portsmouth Hospital, just because I would want that to be your true experience, and I wouldn't be confident without knowing everything you're going to have done that would be your true experience. So to me, that's where the rub is.
Other responses from the panelists? Okay, we are running tight on time, but we're opening up to the public comment period. I just don't want to hold these folks hostage.
Thank you.
We asked you at the beginning of this hearing to think about the 3 questions that you see up on the board now. Has anyone given them any thought? Does anyone have any comments to make that would be for the benefit of all? Or at least some? Who's got, how about the person? Yes.
I think that's because
Oh, I have my hand up. Well, yeah. Okay. Regarding the first question about can the patient be an informed consumer, I think there's plenty of evidence out there nationally that the patient can be, but it really depends on multiple factors. And obviously, this is a very complex area that we're talking about. But I just want to mention 3 organizations. One is the state of Indiana with 65,000 plan members. One is Kraft Foods, and another is Cummins Engine. Each of these organizations is shifting towards CDHPs, and for Kraft and for Cummins, they are making CDHPs and what are called account-based health plans the only option. Now, these put a tremendous amount of responsibility on the employer and the employees to find pricing, to find low-cost providers so they can basically take advantage of the tax advantage accounts, the HSAs and the HRAs. We haven't heard a whole lot about today, but I just want to mention in Indiana, Mitch Daniels began in 2004 when he was running for governor to make consumers have more skin in the game. So in 2006, they introduced a consumer-driven health plan in addition to PPO and others, and they had adoption of 4% in 2006. 7 years later, and this is all voluntary, 96% of plan members were on CDHP. At the same time, the plan members had accumulated $59 million in their own HSAs, which don't go away, which stay with them. And the health risk scores for the population had improved in spite of an aging workforce. So I think there's plenty of evidence that patients can be informed, but it requires tremendous amounts of work on multiple parties. And I think one thing I did want to mention about, I've been reading a lot about insurer incentives and broker incentives and patient incentives, and I don't think they're always aligned. And I think that was one of the things that was sort of coming out. Sometimes things are a little hidden here, a little hidden there, transparent here, transparent there. For many of us, and I'm a consumer, I'm not Harvard Pilgrim, it can be very confusing. And I think human nature, a lot of us don't want to do a lot of work, so it even makes it more difficult. But I think we can be informed, and I think we can drive costs down.
Thank you. Did you have a comment?
Yeah, well, I was going to say, thank you for putting this on. I think it would be really wonderful to have an employer panel, an employee panel outside the industry in a future event, because we're missing, I think people are getting frustrated about some of the group that's kind of right over here. A lot of this frustration comes from the fact that I've been an employer in the state of New Hampshire since 1989, employing gobs and gobs of professionals and having to set up their benefits programs and pay the premiums and watching year over year those premiums go up faster than anything else on my budget, including by far even software developers, hardware engineers. And having experience in 2005 with my fourth company, where I forced, as the founder, president, CEO, upon my employees, a high deductible health plan, max out of pocket, $5,000, $10,000 for family plan, where the premium dropped 60%. I took the drop in premium, I fully funded 100% of the health savings accounts for the employees. I indemnified everybody for the difference between those accounts and when the insurance would kick in. And the first year, my company saved 32% total cost over what it would have been done to do it the traditional way. And I surveyed my employees, and the money I gave them, they had 75% of it left. I watched my Canadian wife, Canadian, you know what that means, social insurance wife, actually ask the doctor whether or not there was a generic for the drug. I watched her check at the go to the pharmacy and try, well, if I pay you cash with this credit card now, am I going to get the right price? And what you find out is that the entire system, and I know this is a negative word, but I got to tell you, his story is not news story. His story is everybody's story. The entire system is rigged for a third-party payer system. It is not friendly to the consumer. And you hear statements up here, it's too complicated, there are too many codes. Well, I dropped my fairly sophisticated automobile at the dealership, right? And they are required by state law to give me a written quote that I have to sign off on before I leave, or they can't expect to get paid. And if after they open up the hood and they take the head off the engine, they find out that the valves have dropped into the cylinders or whatever it is, and I don't know what these things are. I mean, they have to call me and say, hey, we discovered this new thing, and if we're going to do this next thing, it's going to cost a bunch of money. Now, I know you're in the operating room, and you're probably not going to be looking to get a phone call about your wife in the operating room, but it really is crazy to suggest that people should not be allowed to get involved in their own health care and their own.
So what you're suggesting then is that in the future we should consider employer and or employee panels?
That would be helpful, because then at
Thank
least
you.
everyone wouldn't be looking at us and saying, hey, you're the guys who are the bad guys in the room.
Thank you.
Okay.
Other comments? That's it? You're all ready to go back to work? Okay. Well, thank you very much for joining us today. I thought it was a very informative session. I thought some good comments came out of the session, and look forward to seeing you all next year.